Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Okay, we're going to get started with the man who needs no introduction, Douglas DiRuggiero, speaking about Bullous Pemphigoid today. So, Douglas, please walk us through the typical profile of the Bullous Pemphigoid patient and your approach to initial diagnosis.
Well, I can say that the typical BP patient is not what you always see in the textbook photos. So that would be the first pearl. The numbers tell us that 20% of patients who have bullous pemphigoid present with only a pruritic presentation or pruritus with an urticarial presentation before they actually begin to manifest with vesicles and bullae itself. So I have been trained, and I believe in my experience is true. Any patient who is over the age of 65 that is presenting with chronic itch, with or without urticarial, is bullous pemphigoid until proven otherwise.
Wow.
And I think that Gil Yapovich, the doctor of itch, I've heard him say that as well as we've lectured on pruritic disorders. And so it has to be in every decade that you live, your increased risk of having bullous pemphigoid increases. In fact, you're 80% more likely to develop bullous pemphigoid if you live to be past the age of 90 than you are if you're between the ages of 60 and 70. So each decade that you live significantly increases your risk of being a person who could develop bullous pemphigoid. Now, it's it's almost equal amount men and women, okay, and across ethnic groups. But it's a little more likely to be bullous in men between ages of 60 and 80, and a little more likely to be pruritic in women 80 and beyond. So there are some small nuances, but the numbers are very, very close to one another. I don't know if that answered your question. Are you looking for like patient demographics?
That actually answered a lot of our questions, Douglas.
Yeah. Okay.
So with age, does that presentation tend to change when patients are a little bit older? Are we still seeing the tense bullae that we hear about in the textbooks, or does it seem to shift a little bit?
Well, I think the key is that if we're separating a bullous disorder from a pemphigus disorder, we classically see more tense bullae. And if you understand what's happening, then it makes sense to you. This is truly an autoimmune disease, okay? Or we can identify the autoantibody that's there, and we call this bullous pemphigoid antibody 180 and bullous pemphigoid antibody 230. Those are the two that have been identified. I don't know if there's a 179 and a 235. I don't know where those numbers came from, but we have a 180 and a 230, and our body is basically creating an attacker cell against itself, hence an autoimmune problem. And in this case, it's not creating an attacker cell against the thyroid, like in Hashimoto's disease, or an attacker cell against our vascular supply, like in lupus. It's creating an attacker cell against the skin's adhesion cells. And so with bullous pemphigoid, the attack is happening right below at the lower surface of the DEJ, the dermal epidermal junction. So when that attack happens and those hemidesmosomes are obliterated, then the skin separates. And our body hates empty spaces. It will fill it with fluid. But what is above it? Well, what's above it is all 5 layers of the epidermis. And so it pushes that area up. And that's in your full thickness of your epidermis, while not as thick as the dermis, creates a blister that you can kind of bounce your finger on. You almost have to take something sharp to get it to rupture. Pemphigus and the pemphigus things that happen, and some other things like IgA and epidermal bullosa, those kind of things, they're attacking in the middle of the epidermis. Yeah, that's where when we go from the lowest layer, the stratum basale, we go up to the spinosum and the granulosum. Those cells have these little things that are holding hands, these desmosomes, these spindle cells. It attacks those. So it obliterates up in the epidermis. And since it's obliterating the epidermis, that blister is very thin, shallow, and fragile. In fact, it ruptures often before you see it in the office. They present as shallow crust and ulcerations and things like that. Here's the caveat to it, is that the older you get, the thinner our skin gets. So if you get someone in who's 85, 90 years old and they've already got thin skin and benign pigmented purpura, if they develop bullous pemphigoid, even though they're pushing up all the layers of the epidermis, their epidermis is pretty thin. And so they may almost look pemphigus-like, because of the thin skin. Now, it may not look that way on the back. So if you're looking at highly sun-exposed areas where we tend to see more skin thinning because of, long-term radiation exposure, if you're looking at just those areas, you can get fooled. So you want to start looking at other areas of the body where they could have more tense lesions. And then, of course, look in the mouth because your pemphigus disorders tend to have a much higher predilection for affecting mucosal surfaces, eyelids, nose, mouth, genitalia. So that's definitely a separator between bullous pemphigoid not involving mucosal surfaces as often, although there's a form of it, and then pemphigus vulgaris, which does involve mucosal surfaces more often. There's a mucous membrane pemphigoid that we see, so that's a little caveat. So
With
again, I may have over-answered your question, but
but
yeah.
with BP, you find that it's trunk and extremities typically, or where does it present on the body?
Well, it can present anywhere. This is an autoimmune disease that presents anywhere. Now, it does tend to have, again, because of the fragility of the skin and because of, sun just not good for us in many ways. It's good for us in some ways. So there can be a predilection of bullous pemphigoid on the extremities, but it certainly has but you're going to see it on the trunk and you're going to see it on the head and neck, and so those are the areas where we typically see it. So
You brought up a great point, though, about skin atrophy and about how so many of our elderly patients will have atrophy in those chronically radiated areas, chronically sun-exposed areas. And this condition can look very different, in the atrophic skin areas. You may not see those intact bullae. So what is your typical workup of the older itchy patient? You said over a certain age, it's BP until proven otherwise with
yeah.
certain patients with certain presentations. So what is your workup and how do you keep BP high on your differential?
So the only way you're going to definitively rule out BP, and of course BP can be drug induced as well, so we can talk about that in a second. So if you think it's bullous pemphigoid, then your biopsy is going to be really the thing that's going to help you the most. And that biopsy is going to come in the form usually of 2 biopsies. Those who are experienced would know this, but I never assume that everyone that I know anything when someone's talking to me, but you're going to do a punch biopsy that's going to capture about 1/3 of the blister and 2/3 of the skin right beside the blister, send that off in a regular bottle in a formalin, off for an H&E. Then you're going to do your second biopsy that's typically at least 1 centimeter away from a lesion because the activity is still there, but it's not yet separated. And that's going to go inside Michelle's medium, and this is going to not fix the tissue so they can go off for a direct immunofluorescence. You can put it in normal saline. It just simply has to be fully processed within 72 hours. Most labs can't do it that fast because they have it sent to a specialty lab, so you're going to put it into this Michelle's median. They're going to run a direct immunofluorescence on it. You're going to look at this pattern of where it's separating. And with bullous pemphigoid, it typically separates at that subepidermal layer. It's typically going to see IgG and complement 3 is generally what they see lining up there, and then that kind of helps you a lot. On the H&E, you're going to see that same separation area, going to see a high influx of usually eosinophils, sometimes neutrophils, so that helps. Now, you can do an indirect immunofluorescence or an ELISA. That's on serum. You can draw blood and you can ask for those things to be done, and you can look at BP 180 and 230 levels in the serum. And there are a small subset of patients, about 7 to 10%, that can present with positive indirect immunofluorescence serum, not yet have manifestations on the skin. So
Would that precede the actual blister?
I don't know the answer to that. I don't know the data well enough to say if it precedes it, but I do know that but it does show response to therapy. They do at these bullous pemphigoid clinics, at like the Cleveland Clinic that has a lot of folks there. With John Zune, who works there, kind of one of the probably the most prominent person in BP that's alive. They can see response to therapy looking at serum level. I don't know if they actually can predict it, but since they're doing trials, when they have someone that's suspicious of that chronic itchy patient, they say, well, let's do a workup for them. They'll include. I'm not recommending we include, but at a trial center, they're going to include that BP. Direct immunofluorescence, and look at this. So the workup for the itchy patient that's elderly is always putting on your thinking cap. Is this a malignancy? Is this something to do with their drugs? The elderly skin is supercharged to itch anyway. And so it's kind of, I say it falls into 3 or 4 categories. It's either a recognizable disorder that you can diagnose, or it's a dermatomal disorder like neuropathic, radiobrachial, something like that, or it's in the middle, that it's not they itch a lot, but it's not recognizable in anything. And then you start the thinking cap, biopsies, lab work, things like that.
So we don't want to make the assumption that it's just cirrhosis, dry skin, getting older. I think we kind of put our head on that a lot of the times. So we have the diagnosis, we've done our biopsies. How do we explain this to the patient in a way that's very simple, clear, easy to understand?
Yeah, once you know you have the diagnosis, then talking to them and saying that you've got a disorder where, for reasons we don't know why, our body is made to create attacker cells against things. That's what helps us. We get things that try to enter into us. We get infections, we get viruses, we get allergens. And our body has been gifted this ability to create an attacker cell against those unwanted things. But for some reason, it gets tricked. And it creates an attacker cell against itself. And in this case, it's creating an attacker cell against your skin. And it's making your skin separate underneath the layer and form these blisters. Now, it's not just a blistering skin disorder. This disease has a lot of comorbidities associated with it. So when patients respond to therapy, they feel better. They have a lot of fatigue. They have comorbid conditions with thyroid problems, with cardiovascular problems, with liver problems, with GI symptoms. And so there are a lot of other comorbid conditions that follow along with bullous pemphigoid. They just don't feel good until then. Then you get them on the therapies like steroids and the traditional things that we can talk about there. I don't know if you want to go in the direction of therapies or not, but yeah.
We would actually love to go in the direction of therapies, Douglas. Can you please give an overview of current therapeutic options for bullous pemphigoid?
Well, we only have, I don't want this to sound promotional, but we only have one approved medication for bullous pemphigoid, the first ever, and that is dupilumab. So we finally have something that's actually taken the time to run trials and show that there is an improvement of being able to get patients tapered off of prednisone more quickly and to maintain them. And the way that dupilumab ran their trials was actually knowing that the patients, they're washed off topicals, but they actually were on systemic steroids. They put them on systemic steroids, what they considered mild to moderate cases, 0.5 milligram per kilogram or 0.75 milligrams per kilogram for more severe cases. And they were on these steroids at that dose and starting dupilumab for 6 weeks, and then they began to taper them off of it. And they had to be completely off of it by week 16 and be no new lesions forming for 2 weeks. And then they watched them for a maintenance period. So I don't think, if you hear that dupilumab works with bullous pemphigoid, the way it works is that still the drug of choice is systemic steroids up front to get them under control.
And not just a Medrol dose pack or a
No,
2-week
these
short
are,
taper.
No, these are, like I said, anywhere from 0.5 to 1 to 1.5 milligrams per kilogram, and you go down at most 0.5 milligram per kilogram every 2 weeks. Typically, we're starting at 80 milligrams orally, and we're taking them down to 60 milligrams 2 weeks later, 42 weeks later. These are 2 to 3 month tapers. If you take off too fast, they have a recurrence that is there. So historically, we're going to try to find ways to get them off steroids, right? And so that's when all the other alternative therapies come in. Certainly, all your tetracyclines are helpful. Doxycycline, minocycline, dapsone has been used, nicotinamide as an adjunctive therapy, and then you move into methotrexate, mycophenolate. I use a lot of mycophenolate for these patients. Of course, if it's mucosal involvement or the oral form I told you about, rituximab, when you're dealing with pemphigus, is the drug of choice, particularly for ocular. I would say we consider malpractice to not get someone on rituximab immediately if they have ocular pemphigus, because it's that needed and that rapid of a progression. But a lot of alternatives. But right now, it's a drug that we love and that we know how to use, and it's in the same dosing. It's approved in adults. So why not get them on something that, and so far I've put 4 patients on this, on dupilumab for bullous pemphigoid, and all of them I've been able to take off steroids. They still use topical steroids a little bit, and so far they've been had very good maintenance of response, being on dupilumab in the regular 2 weeks, 300 milligram adult dose.
Wonderful.
So what are some of the advantages, I think we kind of answered this question already, of having a more targeted therapy for BP as opposed to the traditional immunosuppressive agents that we had in the
Yeah.
past?
Yeah, I still don't know if we truly know why or how it works for bullous pemphigoid. If you're asking about dupilumab, I think all these medicines are somewhat targeted, but it's like the analogy I've used is the B-52 bomber dropping the bombs on the town versus bringing in somebody. I don't think dupilumab in this case is your sniper SEAL, your Navy SEAL sniper, as much as it's maybe a shotgun blast. So, and that's still pretty close. If you're going to shoot someone with a shotgun from 15 feet away, it's not quite as good as a sniper shot. But it is what's involved in this complex disorder are cells that have IL-4 and 13 receptors. And so in these cells, which are these immune cells, which involve both T cells and B cells a little bit, both innate and adaptive immune system are involved. And basically it's Th2. So anytime you're going to be something that is primarily Th2 driven, you got a drug that addresses almost anything that's going to be Th2 in nature. And so, yeah, it's a great advantage because suddenly we didn't have anything that was FDA approved. And so now we can argue for it. So because we got the approval.
And of course, the patient's second question is going to be, so when can I stop? Right before you've even gotten them on drug. Obviously, how do you explain the chronicity of this condition and the fact that we don't exactly know how long to keep them on it, and what do you see the future?
Well, it's a lot easier answer to give if we're talking about DPM. I feel like I'm so focused on this. I don't necessarily mean to, but it is the only thing that's approved because we know the safety profile with that medication, right? Still all the same side effects you got to talk about that are in the package insert, right? Risk of conjunctivitis, et cetera, et cetera. Although a lot of that stuff wasn't seen in those trials. That sure is a lot easier conversation than when can I get off my methotrexate or my mycophenolate? Do you see what I'm saying? You're looking to do those when you're having to put someone on azathioprine plus mycophenolate and to get them off of steroids. Those medications have a lot of blood monitoring and a lot of problems. So it's not like they don't have to ask me when can I come off of it. I'm asking myself when can I get them off of it?
Right.
How soon can I get them off of it? How low can we go? So we're not having to manage these more complex systemic medications, which are valuable to have. But with dupilumab, I'm not asking myself that question. They may, and then my response is, well, I don't think you need to be coming off of it, unless you want to go back to all those blisters. And it's pretty easy to convince them. We've got a drug that can be used down to 6 months of age with no impact on your immunosuppressive impacts. So no, I don't plan on taking you off of it.
And first rule of medicine is do no harm. So we, of course, want to offer our patients safe medications and medications we have faith in. So I so appreciate your time today, and thank you so much for this wonderful discussion. Hope we all learned a lot about bullous pemphigoid.
The enduring content in this episode is sponsored by Sanofi Regeneron.
Thanks for tuning in to SkinSync. Don't forget to subscribe to SkinSync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.